So, good afternoon, everybody. And I'm Estelle Verberg, and it's a home team, a UCT home team session today. So, I am privileged to introduce Professor Jessica Opie, and then she will chair this afternoon's session on low platelets in many different guises. And indeed, I like the title. So from my side, just for those who do not know Jessica, she has had a very broad clinical base in the UK and in Australia, in beautiful places, I think, like Sydney. And nevertheless, she decided to return and to become a hematopathologist in South Africa. We're privileged. She is now heading up the division of hematopathology at UCT, and she is a very, very valued and wonderful colleague who is, with her broad background and her very, very good writing skills whenever we do projects. So those are the things that I appreciate so much of her, is a very big scientific leadership that she gives. And today it's going to be all practical, I think. And so let's get going.
Thank you very much, Estelle. Can I just confirm that you can hear me?
Yes, perfectly.
Okay, great. So I'm just going to start with the housekeeping rules. Firstly, to welcome everybody to this session. We're going to be speaking about thrombocytopenia, and we'll start with Jonathan Oxley, who will be presenting a case. I will then be presenting for about 20 minutes on an approach to thrombocytopenia in the laboratory, and with an update on ITP. And then our colleague Gamu will speak about gestational thrombocytopenia, and Dalian Kriel, one of our consultant hematologists, will speak about neonatal thrombocytopenia. So just to note that the recordings can be found on the Blood SA website, which is a very useful resource, and huge thanks to Estelle and Kherdin and their team for all that they've done to build this and really extend the education nationally and even internationally. Please add your questions or comments into the chat box. I am chairing and speaking, so I may not be able to address them immediately, but we will try and address where we can, depending also on how time goes. Please, if you have any requests for anyone to join the list, contact Melanie. And as I'm sure most of you know, there are CPD points for this session, but you do need to attend for 1 hour to qualify for the CPD point. We do value your feedback. Please complete the anonymous feedback survey at the end of the session, and we do appreciate any ideas or recommendations for improvement. This is our wonderful management team, and I've already run through the agenda, and since we have 4 speakers, so we've got quite a busy, jam-packed, exciting session coming up. We are going to jump straight into Jonathan Oxley's case. I'm sorry I didn't introduce him yet. Jonathan is one of our clinical hematology fellows. He qualified at Walter Sisulu University and has a discovery fellowship to train with us. He's currently rotating through the lab in his training. Absolutely wonderful colleague to work with. And we look very much forward to his clinical case presentation. So please go ahead, Jonathan. I'm going to stop this presentation and hand over to you now. Oops, well, here was a little bit more. I think I've covered all of that. Gamu, I was also going to introduce before she speaks, but she's a clinical hematologist who recently qualified with distinction last year. She also got her MBCHB with distinction, so very highly regarded and fantastic, and we are privileged to have her as a colleague with us and look very much forward to her presentation. And Dillian, I will again introduce towards the end. Dillian trained with us here at UCT after completing her master's in clinical epidemiology at Stellenbosch University, which is a very useful, helpful skill that she has for our training and research. And she is very interested in pediatrics and pediatric hematology. So we look forward to her presentation on neonatal thrombocytopenia. Right, so I'm going to stop. Okay, can you see Jonathan's screen now, Estelle?
Yes.
Fantastic.
Yes.
Please go ahead, Jonathan.
Okay, so just want to check I'm audible.
Yes, I can hear you.
Okay, great. Okay, well, thank you, everybody, for attending today, and it's great to be here with you all. Today, I'm going to be kicking off our series of discussions on thrombocytopenia by looking at a brief case, which we encountered on a recent trip to George. So Kritiski is doing an outreach once every 6 weeks or so to George, where we see hematology patients, and this patient was referred to us when we got there to see as quite an urgent case. So I've titled this presentation, Defying Occam's Razor. And before I jump into the presentation, I just wanted to quickly speak on this. So essentially, Occam's Razor is a philosophical principle, which is often used by clinicians and in diagnostic medicine. And basically, it recommends that the explanation or diagnosis with the least number of assumptions or elements should be the preferred diagnosis. Why would you invoke two different diseases when one can explain everything? And in one sense, it seems reasonable and rational. But in another sense, when we face real medical problems in the wards, especially in clinical hematology or HIV medicine, I think we need to be wary of reductionist explanations that try to tie everything together with one simple answer. And as we know, the truth is often complex, and there's often more than one disease process at work. So hopefully this case highlights that point, and we'll see as we go along. So it revolves around a patient, Mr. M, who's a 33-year-old man from Knysna, who is HIV negative. In 2017, he contracted drug-sensitive pulmonary tuberculosis and was fully treated. And unfortunately, in 2022, he again had symptoms of TB, was tested, had drug-sensitive pulmonary tuberculosis. But this time his treatment was a bit more complicated. He had multiple pneumothoraces and struggled with his treatment. And unfortunately, was still sputum positive in January 2023. However, he was culture negative. And so this was thought to be dead bacilli. And he completed his TB treatment in February 2023. Unfortunately, though, he had fibrobullous lung disease, as you can see on the image on the right, and had an MMRC functional score of 2. And so left with quite a lot of residual morbidity. So our index presentation all starts on the 5th of August this year, when he presented to Knysna Hospital with features that were very concerning: fevers, coughing, diarrhea, severe and prolonged epistaxis, hemoptysis, and a severe thrombocytopenia, platelets of 6. And he was promptly referred to George Regional Hospital for further care. And at George, he was noted to be very pyrexial, normotensive, but tachycardic, and saturating at 91% in room air. His chest X-ray looked even worse. Looks like there were diffuse infiltrates bilaterally. He was in respiratory distress. He was clubbed. He had generalized lymphadenopathy, wet purpura, petechiae on his torso and his legs, and tender hepatomegaly, very unwell. And this slide just documents his course in the hospital. And don't get into the details, but what I want to show you here is his baseline platelets prior to starting TB treatment in August 2022 of 539. And what you can see is from his time of admission for 10 days in George, he had a platelet count of less than 10 that was refractory to any platelet transfusions. He was bleeding at the time, also refractory to his steroids that he was getting, and even got IVIG with no budge in his platelets. Just some important negatives. Hemolysis was ruled out. Important to note that he had no fragments. He didn't have a DIC, His metabolic screen was normal. There was no evidence clinically or on serology of autoimmune disease. And his infection workup was negative, except his TB studies, which were persistently positive. His sputum was gene expert positive, RIF sensitive, and he had a positive urinary lamb. Now, normally we don't do urinary lambs on HIV negative patients. He had one, it was positive. Overall, the significance of these results were not clear, because we know that patients that have had TB before can have persistently positive gene experts and possibly positive lambs for up to 2 years after treatment. So we thought that this might be a false positive. So we saw him in George, and he was really unwell, was bleeding at the time of seeing him. And we decided, no, he needs to come to Groote Schuur because we have more treatment options available. And so he flew on that same day on this plane through to Groote Schuur Hospital. And on arrival, there were several things that we needed to consider as a clinical hematology team. First of all, our working diagnosis was refractory ITP, and this was on the basis of these very low platelets and that were refractory to platelet transfusions. And the next thing we needed to consider is what treatment options could we now offer him? And so our 3 options included thrombopoietin receptor agonists, such as eltrombopag, anti-CD20 monoclonal antibodies, such as rituximab, and we even considered splenectomy in this patient as a possible treatment option. The other issue that we needed to consider was, does he actually have concurrent TB? He was feverish, was very unwell, and there was definitely something else going on in the background, but could we trust those TB results? So eventually we decided to go for rituximab in this patient, and it's easier for us to acquire this than to get eltrombopag. It's also cheaper and is a more defined period of treatment. And splenectomy, he was quite unstable when he came in, and quite a radical procedure. So we decided to go for rituximab. And in terms of the TB, we decided in conjunction with our infectious diseases department and medicine department that this was not active TB, that we shouldn't actually act on this yet. We should wait for further cultures to see if anything emerges. And so this is how we went forward in this patient. We then got the bone marrow trephine. As we decided to marrow this patient, there was something else going on. And the first thing to note on this trephine is that this patient had an abundance of megakaryocytes. And this was reassuring in terms of our diagnosis of a peripheral cause of destruction of platelets in keeping with ITP. And as you can see in the slide, there's multiple different megakaryocytes in a small area. So this was really looking like ITP with peripheral destruction. But was also noted on his marrow is this under low power, but this under higher power is that he had numerous granuloma, and some of them with multinucleate giant cells. The pathologist that originally reviewed this slide really scanned this carefully under oil and actually noted that there were some acid-fast bacilli, Zeal-Nielsen positive and PAS positive. And so again, there was this evidence for TB, but again, in discussion with ID, we thought this could all be in keeping with previous TB. Just to say that this was his response to rituximab. So we gave him rituximab on the 21st of August. And by the 28th of August, he finally had responded and his platelets had jumped up to 175, had a brisk response. But we knew that we did need to keep an eye on this patient, as many patients on rituximab do relapse. So we're going to be watching that going forward. But what we then found was that his culture came back. And it now showed that he actually had cultured Mycobacterium tuberculosis. And so what we have here is a 33-year-old male that's HIV negative, multiple episodes of pulmonary tuberculosis with fibrobullous lung disease. And this probably made it difficult to treat this TB, as there's a degree of decreased drug penetrance into these cavities. He was also steroid platelet and IVIG refractory with severe bleeding. He was responsive to rituximab. But ITP was not the only thing going on. He also had a second diagnosis. He had disseminated TB. And this just illustrates that in these patients, especially in HIV positive patients, he wasn't positive, but many of our patients are immunosuppressed. We do need to consider more than one diagnosis simultaneously occurring in a patient. And this is what we see here. So in terms of Occam's razor, very useful principle, but needs to be used with caution in complicated medical patients. And with that, I'm going to hand over to the rest of the team to look more deeply at thrombocytopenia. Thank you.
Thank you, Jonathan. That was an excellent presentation and a great way to kick off our discussion. I'm going to share my slides now for my talk. So can I just check if you are seeing in the correct view?
Not yet.
Okay, let's try now. Try again. There we go. Is that working?
I don't see the share screen yet.
Don't you see the share screen?
Is it just me that doesn't see it?
Just a second. And now it's done?
Coming. Perfect.
Perfect. Okay, great.
So yeah, it's not yet in the presenter view. There you are. Perfect.
Perfect. Great. Thank you. Okay, so I'm going to speak a little bit more about thrombocytopenia. So thrombocytopenia strictly is defined as a platelet count below the 2.5 lower percentile of normal. But in fact, platelet counts between 100 and 150 are not necessarily disease if they have been stable for more than 6 months. And a cutoff, and many international publications agree that a cutoff of 100 is actually more appropriate to identify pathology and to investigate for pathology. And that is the definition also included in the modern definition for ITP. So thrombocytopenia causes a defect in primary hemostasis with mucocutaneous bleeding, which is clinically significant, often with a platelet count of less than 20. But even if the platelet count is more than 20, thrombocytopenia, a milder thrombocytopenia, can aggravate surgical bleeding or prevent effective treatment for certain conditions which may be associated with additional thrombocytopenia. And importantly, thrombocytopenia may be the first manifestation of an important serious diagnosis warranting specific treatment, such as HIV or MDS. Establishing the cause, a very simple approach as we would for any cytopenia. The major mechanisms are a decreased production in the bone marrow and increased destruction, increased peripheral platelet destruction. And generally the workup for these patients is much more straightforward in outpatients and more challenging for inpatients where there are multiple, often different pathologies, for example, the patient that Jonathan presented. A structured approach is very important with a careful history, physical examination, laboratory tests, and of course, radiology tests or any other tests that are indicated. And generally an isolated thrombocytopenia, which is not associated with abnormalities in the other cell lines on the blood smear, is ITP or drug-induced ITP until proven otherwise. And I'll go into that in a bit more detail. So I looked at the various articles that have been published recently. And in fact, this one from Ash, which is now about 10 years old, gives a very nice approach to thrombocytopenia. Of course, in America, things are a bit different when they talk about outpatients and inpatients. In our setting, patients with, TTP that are really sick can present at an outpatient. But generally, if we can divide it into well patients and sicker patients, so the well patients, we have immune thrombocytopenia and a drug-induced thrombocytopenia, very important and very common. Infections, particularly viral infections, and in our environment, HIV, particularly important, as is hepatitis C, also hepatitis B. Connective tissue disorders always need to be excluded. Recent vaccinations, myelodysplasia, congenital thrombocytopenias that Dr. Creel, Delian will be speaking about, and more rarely, a presentation of a common variable immunodeficiency. Now, I was quite interested in this ASH approach that they didn't actually mention chronic B lymphoproliferative disorders because, of course, a presentation of CLL, for example, could be an Evans syndrome, where you have autoimmune hemolytic anemia and thrombocytopenia. In terms of inpatients where patients are much sicker, there are often multiple competing pathologies that can contribute to thrombocytopenia. And here we're looking at bacterial infections, sepsis, viruses, the microangiopathic hemolytic anemias, DIC, liver disease, heparin-induced thrombocytopenia, HLH, which they call macrophage activation syndrome, bone marrow disorders, and chemotherapy. The cardiac patients have a more sort of short list generally. Patients on bypass, we know, develop a transient thrombocytopenia. The drugs that are used in cardiac patients have a risk of thrombocytopenia, and particularly here one to watch for is HIT, which can be very serious. And then patients who have had a lot of product support can develop a dilutional thrombocytopenia. Pregnancy and postpartum thrombocytopenia is a separate category, which Gama will go into in a bit more detail, which varies from gestational thrombocytopenia, which can be very mild and not require any investigation, to presentations around labor like HELLP syndrome, preeclampsia, abruption, and of course TTP. So the workup, once the history's been taken, the blood approach, the lab approach is very, very important. The blood smear has to be examined because the very first thing to exclude is platelet clumping. So if it's a true thrombocytopenia or an artifactual thrombocytopenia, and this may sound very obvious, but we've had patients that have been referred for ITP and even treated for ITP that in fact had platelet clumping on their smear, which of course is not a true thrombocytopenia, it's artifactual. So that is the number one cause to exclude. So is it a true thrombocytopenia? And then on the smear, there are a number of different pathologies that one could be confronted with, and they are very varied. The hereditary thrombocytopenias are much rarer, and I'm sure Delene will mention more. This is just an example of a May-Heglin anomaly with large platelets and a neutrophil inclusion. One thing that we see fairly regularly is the fragmentation hemolysis, which is where we're really looking for these histiocytes, nucleated red cells, polychromasia, which are the telltale sign typically of TTP. And we need to exclude DIC in these patients, which is why we need to do the baseline coagulation screen, and of course check for the biochemical markers of hemolysis, and typically the LDH will be sky high in this scenario. Alternatively, there may be circulating malignant cells, pathological cells. For example, I've just given one example here of a patient with acute lymphoblastic leukemia, who these patients then, of course, need to go on to have a bone marrow biopsy, as is the case with any leukoerythroblastic picture. The dacrocyte is a teardrop. In America, they use the term dacrocyte. A leukoerythroblastic picture which doesn't have a clear cause, and particularly if there are teardrops, which would indicate bone marrow fibrosis. This is an example of spherocytes. If there is additional agglutination, then we need to be thinking about, could there be a lymphoproliferative disorder, and the sphere should be very carefully examined for a lymphocytosis and atypical lymphocytes. If there are many atypical lymphocytes or reactive lymphocytes, toxic granulation, these features would suggest an infection. I've included here a reactive lymphocyte with plentiful cytoplasm with the scalloping, typical of scalloping around the red cells, which we see in viral infections, very non-specific in viral infections. And then an isolated thrombocytopenia. And the Americans emphasize this issue of the isolated thrombocytopenia, but I think in our setting, in fact, even for an ITP, by the time they present to us, they often do have an associated anemia, particularly an iron deficiency anemia from chronic blood loss. But certainly HIV may present with a isolated thrombocytopenia and hepatitis, Helicobacter pylori. So the investigations, they are based on clinical assessment, and not to forget all the systemic investigations that need to be done as well. I've just put an example here of liver disease. This patient had a platelet count of 26, and we know there are many reasons why patients with liver disease develop thrombocytopenia, and here you can see some telltale target cells. Okay, so immune thrombocytopenia, and for those of us that have been around a long time, this used to be called idiopathic thrombocytopenia, but the nomenclature is definitely immune thrombocytopenia. And I'm going to focus on that now for the next few slides. So the clinical presentation is very varied. It can vary from completely asymptomatic to life-threatening bleeding. About 5%, fortunately very few, present with severe bleeding requiring urgent treatment. And even those who don't have severe bleeding generally report fatigue and a reduced quality of life, and that is even if they don't have anemia. So there are systemic sort of complications of having ITP, and not to forget that they also have an increased risk of thrombosis, so they've got a twice increased prevalence of thrombosis, which can be particularly difficult to treat in view of balancing up the bleeding and thrombosis risk. And the pathophysiology of ITP remains actually quite complex, and it's not completely understood. The blood smear and the bone marrow aspirate, and this is from this very nice article in the New England Journal of Medicine, you would typically be looking for an isolated thrombocytopenia with no other pathology, significant pathology on the peripheral smear, and the bone marrow aspirate is typically normocellular with plentiful megakaryocytes at all stages of maturation with no significant dysplasia or other infiltrates. Pathophysiology, and this is a very nice cartoon from that New England Journal NEMJ article. So the traditional concept that we're all familiar with is the antiplatelet autoantibodies, which are these little Y-shaped bodies on the illustration, and you can see that they bind to the platelets and they bind actually to megakaryocytes as well. So not only do they bind to platelets, leading to platelet phagocytosis when they bind the FC receptors in the macrophages, but they are actually also impairing megakaryocyte maturation and platelet production, beg your pardon, in the bone marrow. The other interesting thing is that these autoantibodies actually lead to activation of the FC gamma receptors, and this is controlled by a splenic tyrosine kinase, which they have now developed a novel inhibitor for. So there's an oral tyrosine kinase inhibitor, which has shown some promising results. But the story is not completely clear because only about 50 to 60% of ITP patients have platelet antibodies. So what else could be going on? And there's been a lot of work done now on T cells and the role of T cells. And in fact, the T cells have a skewed repertoire. There's a reduction in the regulatory control by T cells, which could be driving the autoimmune process and sort of unleashing the B cells and plasma cells to produce more autoantibodies. And there's also some evidence that cytotoxic T cells directly destroy platelets and inhibit their production. So primary ITP, in terms of international recommendations, it's a diagnosis of exclusion. There's no actual diagnostic test for ITP. In these recommendations in Blood Advances in 2019, they are recommending the routine testing for detection of Helicobacter pylori. This is after the full blood count and expert smear review. So a pathologist or a technologist who is experienced needs to examine the smear. It's very, very important. Testing for viruses, immunodeficiencies. Bone marrow is only for patients not responding to upfront therapies or where you are considering splenectomy, or if other abnormalities have been seen on the smear. And this bone marrow should include flow cytometry, and cytogenetics. In terms of classification, ITP is either classified as primary or secondary. It's secondary if there are other associated medical conditions at diagnosis. Obviously, the treatment of primary ITP can also cause medical conditions like diabetes, etc., but that wouldn't count as secondary. And then we have the terminology of newly diagnosed ITP, persistent ITP, and chronic ITP. And I would just like to share some brief feedback from the British Society of Hematology. I was privileged to attend in April this year. And one of the doyens of ITP, Professor David Kuta from Harvard, who actually discovered some of the TPO agonists, spoke about changing the approach to ITP. Are corticosteroids necessary? So he spoke about steroids, saying they still are very important for treatment, but we should be aiming for a really short course, less than 6 weeks, including the taper. Splenectomy should be avoided for at least a year. In terms of the ASH guidelines, if a platelet count is less than 30 and the patient is asymptomatic or they're minor bleeding, steroids are recommended, and this is a grade A evidence, between 0.5 to 2 milligrams per kilo per day. And if it's greater than 30, there should not be steroids given. If the platelet count is less than 20, admission of the patient is advised, and ASH suggests steroids alone versus steroids and rituximab in the initial phase. How do the steroids work? They increase platelet production from the megakaryocytes, reduce autoantibody production, and reduce that FC receptor-mediated macrophage clearance by the spleen. Other agents that can be considered in initial acute treatment include IVIG and IV anti-D immunoglobulin, but this is not widely available in many countries and only would apply to rhesus-positive patients. After the initial ITP treatment, not everybody responds. So we're only looking at about 30% at 6 months. Well, we are looking at about 30% at 6 months that have a platelet count of greater than 30. So those patients are now looking towards a chronic ITP because about 70% of them still have significant thrombocytopenia. It's a very unpredictable disease. Remissions can occur after many years after diagnosis, either with or without therapy. If patients relapse with bleeding or severe thrombocytopenia, the options include the thrombopoietin receptor agonists, rituximab, splenectomy, and oral fostamatinib, which is a new agent which inhibits that splenic tyrosine kinase inhibitor. And he recommends, from their study, that the TPO receptor agonists are better than rituximab, and that rituximab is better than splenectomy. So just in summary, in terms of the TPO receptor agonists, they have shown prolonged efficacy for at least 8 years, stable dosing, reduced bleeding. They can completely reduce or eliminate the need for other ITP meds. But the platelet counts vary still from week to week, and they are not a cure. So many patients relapse if the agents are stopped. But about 50% enter remission. They have an identical response profile if they started early or late, and they may be able to predict response. So I'm going to stop there. I think I'm just on 20 minutes. I've given just a brief overview to thrombocytopenia, which is one of the very common daily conditions that we all confronted with at all levels in hematology, from interns, registrars, GPs, specialists. I've tried to give you some definitions and a diagnostic approach, clarify the difference between a primary and a secondary and how to exclude the secondary causes, and touched on the approach to management of ITP, and including the recent BSH presentation. Of course, unfortunately, the TPO receptor agonists are still very expensive and not widely available. So thank you for your attention. I am going to now hand over to Gamu, who is one of our recently qualified clinical hematologists. We're very proud to have her in our division. She qualified with distinction. She qualified her MBCHB with distinction and her MEd with distinction, as far as I know. So let's hand over now to Gamu.
Okay, thank you for that lovely introduction, Prof, and that great overview. I'm going to go ahead and share my screen. Okay. I think you can all see my presenter slides, actually. So let me just change that a little bit. All right. That's better. You can't see my presenter slides, yes? So I'm just going to be speaking on thrombocytopenia in pregnancy. Just going to go into the background of thrombocytopenia in pregnancy, and then look at the causes of thrombocytopenia, and then an overall approach to thrombocytopenia in pregnancy. Right, so by way of background, thrombocytopenia by definition, as we all know, is a count less than 150. And in general, thrombocytopenia does actually occur in about 5 to 10% of pregnancies. And you'll see on those nice images that it progressively, the platelet counts progressively decrease by week of gestation in patients with uncomplicated pregnancies. And this is largely due to physiologic hemodilution, due to large plasma volume, increased platelet activation, and clearance. In patients with pre-existing disorders, the platelet counts tend to be lower and also show the same pattern of a decrease through pregnancy and then an increase in the postpartum period. Right. So in terms of the overall causes of thrombocytopenia, this blood review shows very nicely how each size of a circle sort of represents the frequency of all causes of thrombocytopenia in each of the 3 trimesters of pregnancy. And you'll see that in all trimesters, in the first trimester of all causes, ITP remains the commonest cause. And as you progress through the pregnancy with a platelet count that's over 100, gestational thrombocytopenia tends to be the commonest cause, whereas although ITP is still very common in the 2nd trimester, by the 3rd trimester, pregnancy-related thrombocytopenia becomes more common, particularly with the more severe thrombocytopenia of less than 50. Other causes, as Prof went through, will be similar to the general, well, the non-pregnant population, and includes things like infection, DIC, immune and non-immune drug-induced thrombocytopenias, bone marrow failure syndromes, thrombotic microangiopathies. But my main focus is going to be on the pregnancy-related approach to thrombocytopenia. So with gestational thrombocytopenia, this occurs in about 4 to 11% of pregnancies and accounts for the vast majority of cases of thrombocytopenia in the 3rd trimester, as we saw, but it is a diagnosis of exclusion. It usually also does not become apparent before the mid-2nd trimester, and only about 1 to 5% of women with gestational thrombocytopenia actually drop their counts below 100. So once that platelet count is dropping below 100, then you have to be quite circumspect in terms of assigning a diagnosis of gestational thrombocytopenia, and even more so when the platelet counts drop below 50. Then one has to be quite sure that all other possible differentials have been carefully assessed for and excluded. Particularly because there are no diagnostic biomarkers for this. It is not going to have an effect on fetal-maternal health. And in fact, immunotherapy is not necessary, nor is it effective. However, you might make retrospectively a diagnosis of ITP or hereditary thrombocytopenia retrospectively. One thing to just keep in mind with that is it might also be associated with mild neonatal thrombocytopenia, but usually not severe enough that it would have particular complications for the neonate. If the platelets don't recover sort of within 1 to 2 months after delivery, then again, as I said, that one may end up making a retrospective diagnosis of ITP or hereditary thrombocytopenia. ITP, affects about 3% of all pregnancies. About 15 to 35% require treatment before delivery. The clinical diagnosis may also be made retrospectively if no treatment ended up being required during the pregnancy. But generally, it's a well patient in the first or second trimester with an isolated thrombocytopenia. They may have a personal bleeding history and history of thrombocytopenia outside of the pregnancy. They may have a history that is helpful to exclude hereditary thrombocytopenia, but that's not always reliable. And of course, there's exclusion of other disorders, but otherwise the evaluation is similar to non-pregnant adults, but with special attention to other causes of pregnancy-associated thrombocytopenia, such as preeclampsia, HELLP syndrome, acute fatty liver of pregnancy, and then of course TTP and HUS. And one thing to keep in mind is that although ITP is not a contraindication to pregnancy, where there's been refractory disease and there's ongoing use of teratogenic drugs, then obviously have to have very close collaboration and cooperation between the patient, the obstetrician, and the hematologist about avoiding pregnancy then. In terms of managing ITP in pregnancy, I've sort of divided it into patient who's had platelet monitoring. You sort of determine if delivery is imminent or if delivery is not imminent. If delivery is not imminent and the platelet count is greater than 30, similar to the non-pregnant population, you wouldn't necessarily implement specific therapy at that point, but monitor the counts closely. If the platelet count drops to less than 30 or less than 50 and delivery is imminent, then therapy can be divided into antenatal therapy, therapy at the time of delivery and in the postpartum period. And it's important to sort of think about these different time points because oral prednisone is generally favored over IV steroids, and that's because there is an association with it's more likely to cross the placenta, and there's an association with cleft palate in the first trimester. And then, of course, there are all the complications we know of with long-term steroid use. So you just have to be quite careful about how you initiate therapy. In terms of the treatment, there are some similarities to the non-pregnant population, but also significant differences. So in the first line, oral corticosteroids and IVIG, depending on the timing of initiation of treatment in relationship to delivery and how quickly the platelet count needs to be increased. Second line therapies may be combination of steroids and IVIG, splenectomy in the second trimester. And then the other therapeutic options are a bit challenging in that some are relatively contraindicated, such as anti-D we don't have in any case, but azathioprine. And then some are not recommended, but they are described in pregnancy, such as cyclosporin, dapsone, thrombopoietin receptor agonists. And then drugs such as rituximab are known to cause significant neonatal immunosuppression, generally not recommended. And then, of course, there are the obvious teratogenic drugs such as MMF, cyclophosphamide, the vinca alkaloids. So generally speaking, antenatally, corticosteroids are used. Prednisone is used, but at much lower doses than in the non-pregnant population, recommending sort of 20 milligrams daily to start with. And then other options would include azathioprine, cyclosporin, methylpred, splenectomy, the TPO receptor agonists, and rituximab potentially in the first trimester. At delivery, the delivery is always an obstetric indication for delivery. So patients will not be delivered earlier because of their ITP. And then again, IVIG, steroids, and platelet transfusion would need to be given to sustain or to achieve a platelet count of over 50 if a cesarean delivery is required, more than 70 if neuraxial anesthesia is required, but more than 30 should be adequate for a vaginal delivery. Although I would imagine for most people, it would be quite hair-raising to go into the delivery with platelets any less than 30. For the fetus and neonate, avoiding procedures with any bleeding risk, such as fetal scalp electrodes, electrode monitoring, ventouse delivery, fetal blood sampling, and rotational forceps. And then the pediatrician needs to be alerted about the fact that, you know, there's a mom who's got ITP or had ITP in the past and is post-splenectomy, because there is a risk that the baby will have thrombocytopenia. And then the postpartum period, one want to avoid NSAIDs if platelet counts are less than 50. And if anticoagulation is required, then the platelet count would need to be maintained at greater than 50. As Prof mentioned earlier, there is an increased risk of venous thromboembolism in our patients with ITP. So moving on to other important causes of thrombocytopenia in pregnancy, preeclampsia and HELP. I think we've all been consulted and all have grappled with the patient with thrombocytopenia in their second and third trimester. This is very important. It's a very important cause of maternal death and morbidity in South Africa. 18% of maternal deaths are due to preeclampsia. Patients tend to present with clinical manifestations such as abdominal pain, nausea, vomiting, headache, and HELP is one of the severe complications of preeclampsia. And so it becomes very important to recognize this, because obviously the management is very different from other causes of thrombocytopenia. And there are specific criteria for diagnosing preeclampsia from American College of Obstetrics and Gynecologists on the left there. And the management essentially would be urgent delivery after stabilizing the patient, blood pressure control and steroids for fetal lung maturation, and then risk assessment for future pregnancies. However, if you have sustained or persistent thrombocytopenia or deterioration postpartum, then a diagnosis of TTP or HUS should be considered. It's also uncommon, though, that neonatal thrombocytopenia would occur in this particular setting. Then acute fatty liver of pregnancy. This is quite a uncommon disorder. Occurs in 1 in 5,000 to 10,000 pregnancies. It's caused by an inherited, or rather fetal autosomal recessive error of mitochondrial fatty acid oxidation. I've just got a small diagram there, basically showing that the most common hereditary mutation is in LCHAD, which essentially results in increased long-chain fatty acids being produced within the placenta. This leads to oxidative stress, mitochondrial dysfunction, lipotoxicity, entering the maternal circulation and causing mitochondrial dysfunction, hepatocyte lipoapoptosis. And the presentation really, the disease can cause really severe maternal disease, where initially patients can present with anorexia, nausea, vomiting, abdominal pain, all the way to encephalopathy and liver failure requiring transplantation. And this group of patients will obviously have more prominent renal, hepatic dysfunction and coagulopathy. And the management will include resuscitation with packed cells, FFPs, many platelets, and of course the delivery needs to happen regardless of gestation. And there would have to be quite significant, serious considerations for subsequent pregnancies, as there's a significant risk with each subsequent pregnancy. And there are criteria in place that can be used to diagnosis, named the Swansea criteria, and they look at different clinical, laboratory, and radiographic features in order to make the diagnosis, and apparently actually have 100% sensitivity, although obviously then a 57% specificity. So helpful to know about those when considering this diagnosis. And then TTP in pregnancy is quite rare, obviously affecting women in their 3rd to 4th decades. Important to make a differential between congenital versus acquired, because there are some differences in the approach, particularly if subsequent pregnancies are considered. Also importantly, because actually congenital TTP, the first presentation of congenital TTP is often in the first pregnancy, but congenital TTP only makes up less than 5% of cases of TTP in pregnancy. And in TTP, in any case, complicates pregnancy with placental insufficiency and IUGR. And the presentation can be very similar to pregnancy-associated TMAs, and yet the treatment is obviously very different. The presentation tends to be more abrupt in acquired TTP, whereas in congenital can be quite much slower in onset with an initial just thrombocytopenia and not necessarily obvious fragmentation hemolysis on the peripheral smear. So it's important to be quite aware of that and consider that early in the differential, particularly when you have a patient who you've initially thought of as gestational thrombocytopenia, but reaches those very low platelet counts of less than 50. This How I Treat article is quite nice in showing how to approach TTP in pregnancy. You'll notice a lot of similarities with our non-pregnant population, but essentially after urgent hematologic and obstetric evaluation and confirmation of the diagnosis of TTP in a patient who presents in any trimester with severe thrombocytopenia, with relatively preserved renal function and liver function with normal blood pressure, then a clinical diagnosis of acute TTP with the appropriate peripheral blood smear changes would necessitate management with plaques and steroids, delivery if there's an obstetric indication or if there's already advanced gestational age. If there's an alternative diagnosis, then obviously that should be managed instead. And then retrospectively, for most of us, the ADAMTS13 activity would return either confirming the diagnosis of TTP, and then the antibodies helping to differentiate between acquired and congenital TTP. I've said there, we all know that treatment would be different for TTP versus preeclampsia, where TTP you could manage with steroids, plasma infusions, and plasma exchange, whereas in preeclampsia, obviously the treatment is delivery. Subsequent management of subsequent pregnancies is also important because there would have to be quite clear antenatal counseling about the fact that there is a risk of recurrence in the next pregnancy. When you have congenital TTP, that chance is 100% because of the persistence of the severe ADAMTS13 deficiency, versus in acquired TTP, where if the levels are maintained between 20 and 25%, then the risk of recurrence of acquired TTP is lower, but it's not zero, and would need quite intensive, quite close monitoring that it doesn't recur. And when it does recur, a clear understanding that the risk of fetal morbidity or maternal and fetal morbidity is significant, particularly for IUGR, miscarriage, and second trimester stillbirth. And there's an increased risk of other pregnancy complications, such as preeclampsia, requiring close obstetric follow-up. However, for the most part, it would be watch and wait and close monitoring of those ADAMTS13 levels and monitoring of hemolysis. Okay, this essentially says what I've just been saying. It's a summary slide, noting that in congenital TTP, the mainstay would be intensified schedule of plasma infusions from the first trimester and vaginal delivery at 36 to 37 weeks. And then after that, ongoing plasma infusions. Whereas acquired autoimmune TTP would require preemptive therapy to try and normalize the ADAMTS13, which would often be rituximab, after which you'd have to avoid conception. And then during pregnancy, close monitoring for hemolysis and monitoring of the ADAMTS13 levels with subsequent steroids or plasma exchange. So essentially the TMAs in pregnancy, which we've discussed, will sorry, it would be important to consider the gestational age at the onset of symptoms, the signs and symptoms that accompany the presentation, the laboratory features, and delivery will have different effects on the disease. Okay, just going to. Okay, this slide I think is essentially just this is a little bit of repetition in terms of what parameters to look out for when faced with a patient who potentially has a TMA in pregnancy. And that would be investigating for MAHA with the peripheral blood smear review, hemolytic screen, monitoring fetal placental status with fetal ultrasound and uterine artery scans, and then monitoring for organ damage in order to assist in making the diagnosis and identifying complications. And then the ADAM-TS13 levels to confirm the diagnosis of TTP. And then finally, this is a slide which I've always found quite helpful about approaching women in her second or third trimester with significant thrombocytopenia, looking clinically, looking at the peripheral blood smear, associated liver and kidney functions, as well as coagulation profile, and then determining if it's in the context of normotensive patient or hypertensive patient. Where hypertension is, where the patient is hypertensive, then, you know, looking towards preeclampsia, HELP, and a complement-mediated TMA as the potential causes. Whereas in a normotensive patient, you know, considering ITP, sepsis, TTP, and DIC as the potential explanations for the patient's presentation. Okay, I hope this has been informative. Thank you all for your attention. I'm going to hand back over.
Thank you, Gamu, for that absolutely excellent overview. I think we've got a few minutes to address some of the comments. There have been some interesting comments in the chat. Just from Caroline Stan, she mentioned that with these steroids in pregnancy, we need to aim to use the lowest effective dose to maintain a safe platelet count, but not necessarily a normal platelet count. And also that dexamethasone can cross the placenta, so that prednisone is preferred over dexamethasone, which I found quite helpful. Gamma, was there any comment you'd like to make about that?
No, I 100% agree. I think I might have rushed through that slide, but yeah, in general, intravenous corticosteroids, like you say, the dexamethasone, the methylpred, more likely to cross the placenta. So you definitely want to use the prednisone at the lowest possible dose. They advise starting at 20 milligrams daily, and then, you know, using as little as possible. So if you can reduce the dose from there, then obviously that would be excellent. And in fact, considering starting just with IVIG if delivery is imminent, meaning that you would use steroids for a short period of time as well. So definitely not a milligram per kilo of steroids or a pulse dexa or, you know, anything of that sort. Yeah.
Yeah. So it really is, you know, one has to sort of tailor make the approach for the pregnant patient. There's also been quite a lot of interesting comments in the chat about the use of ATRA in ITP, which I find interesting. This wasn't actually mentioned. ATRA wasn't mentioned in Prof. Kuter's presentation that I attended at the British Society of Hematology, but there has been a publication from China where they've used ATRA in combination with rituximab and had some good results in patients with ITP. Jacques, was there anything more that you wanted to add about that, or any other comments on that?
Jessica, just something that, I mean, I noticed that there was a previous publication also from China. I'm not sure if it's the same group that published, I think it's probably the same group that published the Rituximab ATRA article that I posted, but there was a previous publication in Hematologica, which I can't now remember exactly when it was, a few years prior to that, where they published some data on danazol plus ATRA, and I also go into sort of some laboratory mechanistic studies into why it works and so forth. So just because we don't have free access to rituximab and the TPO agonists and so forth, it's something that based on those studies we've tried and we've had some success. It's by no means, I think, we've had successes and failures. So I think in our setting where we do have limited standard options that you'd see at the standard sort of treatment algorithm that we sort of discussed here, it's something to consider. And then, yeah, I was just actually interested to see that Rytux ATRAP article was published in Blood, and the results seemed quite good. They compared ATRAP plus low-dose rituximab, so 600 milligrams in total of rituximab in 100 milligram doses once a week, versus just low-dose rituximab in a refractory and relapsed ITP setting, and they had a 80% response rate at 11 months compared to about 59% for low-dose rituximab alone. So it seems potentially a option that we could consider in our setting based on our sort of cost limitations and so forth. So
yeah, very interesting. And it's certainly something we would need to discuss with clinical hematologists as a group. We are at 5 o'clock, so I think we are going to move on now to Dr. Delian Creel, who's going to be presenting on an approach to neonatal thrombocytopenia. Dr. Creel is one of the hematology pathologists in our department. We're very privileged to have her. She has a background in pediatrics before she joined us in HemPath, and also a background in epidemiology. Welcome, Delian. We can see your screen. Thank you very much. And can everybody please just mute their mics if by any chance they aren't? Please go ahead, Delian.
Thank you so much, and for the opportunity from Blood SA and Estelle and your team. I'm very happy to provide a small but hopefully concentrated dose of pediatrics in, I think, an audience that's more used to dealing with adults. I will try to focus on only what's really relevant, and of course we won't have time to go into depth in the different causes for thrombocytopenia in the neonate. But nevertheless, I think a crowd such as this one, if you work in hematology, even if you work with adults, it won't disqualify you from a few questions from your patients, definitely, but also from friends and family about babies and their babies. So I'm going to get going. Let's see if we can advance. There we go. So as an introduction, fetal platelets reach adult levels at about 22 weeks of gestation. So when a baby is born, you are at the normal reference range that we are used to for adults. The definitions for thrombocytopenia, mild, moderate, and severe are similar. And neonates have small megakaryocytes with low ploidy, and their ability to respond to an increased demand is actually related to their gestational age. So their reserve and potential to increase production, and so also the risk of thrombocytopenia is inversely proportional to the gestational age. And as medicine improves, babies of a lower and lower gestational age who are born early actually survive. So dealing with small microprems and the complications of these microprems become more and more relevant. Thrombocytopenia is seen in 1 to 4% of all newborns, and this is a larger proportion than we see in children and also in adults. And then if you think about NICU admissions and hospitalized infants and also very low birth weight infants, the percentages are even higher. So your clinical manifestations vary and also are seen in low or very low platelet counts, but the link between your severity of your thrombocytopenia and bleeding risk is also not linear. So that's similar to adults. I think you can see mucocutaneous bleeding, cephalahematomas, and some oozing. And then, of course, what everyone is afraid of is intracranial bleeding. A general approach, as for all patients, would start with emergency treatment. Interpret your patient in the context of the gestational age, like we said, confirm the thrombocytopenia and exclude that there were pre-analytical problems or clumping on the slide, the degree, the time frame. Are there other cytopenias? And have a look at the blood film compared to what Jessica showed us with your approach to thrombocytopenia in adults and how useful the blood film can be. Not a lot is going on the blood film in thrombocytopenia in neonates. Nevertheless, you can sometimes get some clues from very large or small platelets, which we'll come to again, and your immature platelet fraction and mean platelet volume may be helpful if you take all your other results into consideration as well. History of the delivery, the pregnancy, the mother, the baby, him or herself. And then on examination, do you have a well infant versus an ill or unwell infant, dysmorphic features, and then, of course, comorbidities. As we will see with the causes for thrombocytopenia, sepsis, DIC, NEC are considerations, and you need to look for features of those, and then your tests follow. Importantly, the monitoring of the platelet count is also important when figuring out the cause for thrombocytopenia in neonates, and your therapy is mainly directed at the underlying cause. So I think this is a useful exercise if you think about a neonate and the results that you might be confronted with. Someone asks you about this result in a neonate. We can see at the bottom that we do have a thrombocytopenia platelet count of 15, but we also see what looks like a microcytic anemia. And we have on the right, we've got your reference ranges for a neonate. So compared to what we expect in a neonate, the MCV is quite low, and then a fairly legitimate anemia. And why I show this is when you see a picture like this and you see an unexpected anemia with a low MCV in a neonate, please consider that this is actually the mom's blood that has been labeled with the baby's stickers. And you can, of course, also see vice versa, where you have a sample for a mom in labor ward that has a fairly high HB and also a high MCV. And the culprit is the yellow folder lying with the mom in the labor ward. The baby's with her, perhaps if it's a term infant, in the bassinet, and all the stickers are just stuffed into the yellow folder, and the wrong one gets put on the sample and sent to you. And that's just a consideration besides a clot in the specimen, besides platelet clumping on the film. So when you are sure that you're dealing with a legitimate thrombocytopenia in a neonate, remember to start off with your relevant maternal factors. Like Amu explained, if you know that your mom has got thrombocytopenia or a history of autoimmune disease, importantly, pregnancy complications, infections that are known beforehand, a previously affected child who also had a thrombocytopenia, drug exposures, and this includes everything from alcohol, thiazides, different antibiotics, anti-epileptic drugs, of course, chemotherapy agents. So a variety of drugs could cause thrombocytopenia in the neonate if the mom took them antenatally. Was the placenta normal at delivery, and delivery notes? And remember that the relevance of discussing neonatal thrombocytopenia and all of these slides are also future neonates and future pregnancies, and how you will manage the next pregnancy of your patient based on what happened with the current infant. Causes of early thrombocytopenia, so it's conveniently divided into early and late thrombocytopenia, 72 hours being the cutoff. In premature infants, placental insufficiency, intrauterine growth retardation linked to PET or maternal diabetes is seen often. So these babies are admitted, we see them in the hospital, we see their FBCs in the lab, and usually they have a fairly normal platelet count at delivery. The platelet counts drop by day 4 to 5, but remain above 50, and then normalize by day or week 1 to 2. versus infections, especially the torch infections, and also DIC, which could also cause thrombocytopenia in PREMS. And then the term neonates, you actually consider birth asphyxia, and immune-mediated thrombocytopenia is more likely compared to the ones noted upstairs. So both HIE, hypoxic ischemic encephalopathy, and the cooling that is done for HIE contribute towards low platelet counts. And we'll talk more about neonatal alloimmune thrombocytopenia and the autoimmune causes from the mom in following slides. Rarer causes, we mentioned drug exposures from the mom, severe hemolytic disease of the newborn with dilution with exchange transfusion, ECMO, thrombosis, including renal vein thrombosis, different aneuploidies, and then we'll touch on inherited thrombocytopenias, metabolic syndromes, Kasabach-Merritt syndrome or phenomenon. And then if you have a really unlucky infant, myelofibrosis, you can even see osteosclerotic disorders or neuroblastoma in a newborn. Short notes on neonatal alloimmune thrombocytopenia. This is the platelet equivalent of hemolytic disease of the newborn. It's actually not that uncommon, 1 in 1,000 pregnancies, and can often be severe. And like we mentioned, the feared outcome of intracranial hemorrhage is seen in about 10 to 20% of these babies. It can occur in the first pregnancy, whereas children in the first pregnancy are often spared with HDN. And then to note that subsequent pregnancies, you can actually see your baby being worse affected than the firstborn. Classically, you've got a platelet count less than 100 at birth, drops further, and it can last 1 to 6 weeks. And this is due to maternal platelet-specific antibodies that are mounted against paternal antigens that are expressed on the baby's platelets. So these antibodies cross the placenta, and the mom has a normal platelet count. Usually, the repeat offenders are anti-human platelet antibody or antigen 1A and 5B, and it's important to do a cranial ultrasound after delivery. So if you are lucky enough to have those tests available, you can confirm the discordant antigen expression on the mom and baby's platelets and do genotyping for the parents, especially for future pregnancies as well. You would like to transfuse with platelets that are negative for these 2 antigens. If you do not have that available, washed irradiated maternal platelets can be used, and random donor platelets will usually only give you a temporary rise in your platelets. IVIG is given in some cases. So overall, the classic clinical scenario, a severe unexplained thrombocytopenia that's seen early after birth in a term infant, and you don't see evidence for other common causes for thrombocytopenia, and the maternal platelet count is normal. And this is versus the mom with ITP or SLE. So they call this neonatal autoimmune thrombocytopenia in inverted commas, because the mom is the autoimmune producer of these antibodies. Mom mounts antibodies to her own platelets, and she shares antigens on the platelets with the baby. So the baby also expresses the same antigens, antibodies cross the placenta, and then you have destruction of the baby's platelets. ITP versus SLE, ITP is more common. It's apparent from the maternal history. About 10% of neonates with moms with ITP or SLE will develop a low platelet count, and some of those will be severe. It might last quite long, especially if the mom is breastfeeding, a lower risk of intracranial hemorrhage, and then IVIG is given to babies that are severely affected, but data is very limited on the benefits of steroids. In the interest of time, I will not delve into the inherited thrombocytopenias. There's a nice article, a How I Treat blood journal article from June of this year, that talks specifically about neonatal thrombocytopenia, and they've got 2 whole pages of tables that detail the tier 1 genes for numerical platelet disorders that you can have a look at. As our discipline improves and technology improves, and we can do next generation sequencing and molecular tests, this will be better and better characterized, these very heterogeneous inherited thrombocytopenias. So a family history is very nice if you have it, to just point you in the right direction. Platelet size is also useful if you consider, for example, Viscott-Aldrich, small platelets, eczema, immune compromise, X-linked thrombocytopenia. Other conditions that are associated with a normal platelet size, and then large platelets, like Jessica mentioned, MYH9 related or Bernard-Soulier, for example. UpToDate has a less exhaustive table that I think is useful, and also characterized according to the size of your platelets. Late thrombocytopenia, as we talked about before, less than 72 hours. We're now at more than 72 hours. Sepsis and NEC, intestinal perforation, these are the first port of call at this time. Important to remember that you might just be dealing with a delayed manifestation or detection of an immune-mediated thrombocytopenia, so don't forget about them. And then this lovely flow diagram from UpToDate describes exactly the approach we've now touched on, so you can have a look at that. In essence, here on the left, if you have a platelet count above 50 with a well-appearing infant and you keep monitoring and it normalizes at day 10 of life, you do not need to do further investigations. In practice, the last few slides, I discussed with one of our colleagues at pediatrics, a neonatologist, Dr. Shakti Pillay, when I made this talk about how things are actually done in practice. So it makes sense that not all babies have platelet counts done. So we clinically indicated for a maternal reason, or if there's another reason that the baby needs an FBC, you do get these results, and you can pick up a low platelet count. But essentially, cases are missed, especially the PREM babies, the IUGR related or preeclampsia related, even the autoimmune ones, if the child is well and there's no reason to do an FBC. Early cases may be approached as late, as we said, and then severe bleeding. When you have a situation like this, emergency management takes preference over your diagnostic workup, and also to consider alternative causes for bleeding. Of course, intraventricular hemorrhage in PREMs, local factors in the vasculature, and also problems with coagulation, vitamin K deficiency, platelet transfusions. I'll just skim over. As with adults, there's now restrictive transfusion protocols that are favored, even for premature infants. Usually a well baby with a platelet count above 25 is not given a platelet transfusion. Single donor apheresis platelets mostly, and of course, volume-wise per kilogram given more than adults. This is a table from the Grooteskier neonatology protocol that demonstrates your 25 or your platelet count of 25 cut off, and then for between 25 and 50, depending on comorbid conditions, when you would also give platelets. And this is my last slide. Like I said, here in the middle, a very nice how to treat a paper from June this year, UpToDate, and some other papers that you can read, and my email address if you would like to contact me or ask any other questions. And that's all from me. Thank you. Back to you, Jessica.
Thank you, Dillian. This was really an excellent overview of the neonatal thrombocytopenia. I've got one question, which I'm not sure if we have someone who can actually answer it. Are there CMV negative platelet units available in South Africa? Does anybody know? Not that I'm aware of. I think you might be muted, Julia.
I must admit, Jessica, I will have to go double check. It's been a while. I'm hoping someone else has got more up-to-date knowledge on this.
It'd be great to, but you know, if somebody from other centers would know. But for us, even though we transplant, we can't. I mean, I'm speaking now of an adult medicine. We can't find CMV negative units because almost everybody in South Africa are positive. So I was just wondering if there's a specific reason why an infant should not be exposed to it. I mean, there is probably a reason, but I suppose good just filtering leukocyte depletion could be the answer for the infants, I suppose.
Yes, indeed.
Yeah, so which all should be. Yeah. Just, you know, I made a remark about ITP in the baby. You called it autoimmune. What is it? Autoimmune. No. What? So it's from the mum. So what did you call it? Auto something.
Autoimmune thrombocytopenia.
Yeah. So okay. So that's what you called it. But as I remarked, I've seen it. I think if we don't have enough excitement in our lives as hematologists, then really a baby born to a mum with ITP, whether it's in remission or not, that brings a lot of excitement. I can assure you, a mum who has a baby that is delivered with low platelets, it's quite devastating. Very, very difficult for parents to handle. And I have had a case here in Grooteskieu where the lady had ITP 5 years before. And she did have a child with the neonatal form of ITP. So there was a transmission in spite of the fact that she was in remission for a long time. So I think it's just, as I say, lots of excitement. So very important to get the whole ops team on board. I don't know if others have the same experience, but it's really it's one of those things that you can at least prepare for. You can't always prepare for leukemias arriving on Fridays, but you can at least prepare the team for such a birth.
Yeah, I think Estelle, what they cover in these papers are immune-driven thrombocytopenia in neonates in general, and then this immune-driven process is either alloimmune, which is the alloimmune thrombocytopenia because of the paternal platelet antigens, or it's autoimmune, but with that auto, you're still referring to the mom. So that's due to SLE or ITP in the mom. And then, of course, you can have drug-related immune thrombocytopenia as well. But the antibodies that are causing all the problems are usually from the mom side. And as you mentioned, they also say, interestingly, in these papers, if you have a neonate and you really cannot find a cause for the thrombocytopenia, it's an indication to test the mom for autoimmune disease, because it might be the first indication that the mom's got an autoimmune disorder when the baby has got low platelets.
Yeah, but I mean, this is the one thing that you can actually predict, and it can happen. So it's very important that you don't only speak to the mum about getting her platelets up, but really, really, really speak about the risk to the baby. I think it gets missed sometimes. Yeah. So I don't know. I asked the question after all the presentations were so excellent. Wow. After Jessica's, now what do we use as second line? And I don't know. I don't think we can answer it in this session, but that's quite provocative. What does work? I don't know. I don't think there's the time to discuss in depth, but it would be nice to know what others think. We have a few minutes, so.
Yeah, thank you, Estelle. I agree. I think Jacques' comments are very pertinent about, the cost restrictions that we have in our setting and what the agents are that we have available. yeah, you know, certainly it's not, we only have a few minutes left of the session, and perhaps, you know, it might be worth setting up guidelines for South Africa in terms of, you know, the approach, or certainly in the state sector. I presume that in the private sector, you know, these other agents are more readily available. But I'd just like to really thank join us still in thanking the speakers for some really fantastic presentations, and I really enjoyed the session. I hope that others also did, and really appreciate all the input and the comments, and just to wish everybody a lovely evening and drive safe and all the best. Thank you very much for joining us.
Thank you, everybody. Thanks, Jessica. Lovely session. We all loved it. So thanks.
Bye.